because the big debate was, is something better than nothing? I'm in Greene County, we do not have one, and so that was something I was thinking a lot about. My folks don't have this. I have a very high risk area and I need something. And so it was a big internal debate for a lot of us in terms of whether or not we would support that. Through the negotiations, I think the majority deemed that it wasn't worth making the counties lessen the threshold of what this protection can do. So when it comes to moving towards next year, I think that we really need to focus on the counties that are doing it right and what rules they have in their program and trying to mimic those the best that we can. So.
Yeah, so I will shift gears here a little bit. For this next inquiry, I'd like to maybe just
give a little bit. Yeah.
Sorry, in-house politicians are all. So a couple little things. First is that the privacy issue. I didn't emphasize that. That is a big concern, and it is that, the Fourth Amendment protects you from unreasonable search and seizure. Now, in 2014, it was a ballot initiative. I'd rather think it was Amendment 9. I can't remember for sure, but it was a ballot initiative that stated to the voters, do you consider your computerized data, your electronic data, to be just as protected under the Fourth Amendment as your person's papers, effects, and home? And remember, the vote was overwhelming. It was like 75%. And so what could be more of, personal electronic data than your health records? So you really should have, law enforcement should have probable cause before they search and seize your data. So the PDMP is set up to look for probable cause. You're supposed to have the probable cause before you look. So I think that's just a basic constitutional issue. The other thing that I think had more effect in killing the bill this year was a provision that Senator Schaaf insisted on to let it out of the Senate. And it was that use would be mandatory by every physician, every prescriber, every time, for every patient. And if you didn't, there would be sanctions against your license. So the medical community then, that was previously all in favor of this, flipped and said, no, this is weak. So the pharmacy groups were against it, and both of the medical groups, the DOs and the MDs, became against it. And really, when you think about it, if you're going to have it, Senator Schaaf's opinion was, if you're going to have it, then use it, and make the doctors use it. But the doctors are saying, well, I shouldn't really do it if I know, Bill Jones, I've been giving him narcotics for 10 years for his bad back. So the argument is, well, I already know who's, a risk and who's not. Well, if you already know who's a risk and who's not, why are we doing it even in the beginning? So I think that may be another point of contention next year.
Do you think that was, and feel free not to answer this, but I really am going to do you think that was a poison pill?
I'm gonna take Senator Schaaf's statements on their face. I mean, I have no reason to believe anything different than what Senator Schaaf has proposed. So, thanks.
J-Mo says she wants to chime in now too.
Well, since someone said earlier, where's the special session on infant mortality? Representative Frederick raised the issue of the Fourth Amendment. For the 17th straight year, the vehicle stops report data from the Attorney General showed racial disparities in policing. That's about the Fourth Amendment as well. Why are we stopping people based on their ethnicity so often? Where's the special session about that? We were talking earlier about the correlation between oppressions like racism and healthcare outcomes. So we hope that next year the General Assembly will take up and pass Representative Doken and Representative Kirkland's Fourth Amendment Affirmation Act that would enhance, put some teeth into our racial profiling laws.
I think we should just have a bunch of special sessions. Make this as hard as possible. I want to have one quick inquiry here, and it's a question I've been itching to ask. I will open it up for questions right after this, I promise. Let's just all concede that we all want as much money as possible for our services programs. We all want a balanced budget. We all want to pay lower taxes. Let's just all agree on those three things, right? With that framework, I'd like the opinion of our legislators and our former legislator. What are the government programs funded by the state of Missouri that you think are the most needed and the most effective?
Medicaid, that program, and we hear this all the time. I mean, but the Medicaid program is one of the most efficiently run state programs in the state. I mean, I think overhead for Medicaid is 5%, if that. Everything goes to services. It can absolutely be improved. There are innovative sort of ideas and solutions out there. I don't know if folks saw Nevada actually just passed a Medicaid for All program, a buy-in program for their Medicaid program where anybody in the state can actually buy into the Medicaid program. Actually filed a bill to try to do something similar, just limited to the disabled community for it's the Medicaid Ticket to Work program, but basically try to do a buy-in bill. Senator Sifton had the House version of it, and it actually got out of committee and onto the perfection calendar, but I'm sure, as you all have heard, some things kind of broke down in the Senate, if you will. But that's one program that I just think has to be protected. Can it be improved? Absolutely, but it can be improved in the terms by the programs that it provides and coming up with innovative sort of solutions or innovative sort of ways to deliver services. But the actual operation of and administration of our Medicaid program in our state is one of the most effective and efficient.
I would definitely agree with Representative Walker on Medicaid. I also think that a good use, or where we could be putting more money if we had all this money to put into programs, is for seniors, low-income seniors, adults with disabilities. We have a rapidly aging population in America, and so I think that we need to be putting money towards programs that really support caregivers and family members, adult day health programs, things of that nature, so we can really help people age in place with dignity and really have the support that they need, especially low-income folks. I think that's something that I care a great deal about.
Yes, two social workers, if we had endless money, what we would do. But in the essence of time, I will not repeat what they've said. I, of course, 100% agree with them. I think other things that we should be looking at beyond just the scope of healthcare is things like the cliff effect, and that's something that I've talked about a little bit, but that's the social service programming that when folks go a little bit too far, then they get cut off from programs. There's been legislation in the past that's worked on some of that around childcare, but we can definitely improve our social services across the board in terms of empowering people to continue to be successful and not just cutting them off from those particular services. I definitely think early childhood education funding is a huge priority, but of course because of our current situation it's going to be interesting next year, but if we had endless money, I definitely think we should be focusing on that as well as preventive things across the board. And I think I'm glad that Representative Stevens brought up aging seniors, because that is when we look forward in not just in healthcare but in all facets of where we spend our money, that the population is concerning for our budget. And so I think I would love to see some things put in place in terms of attracting retirees to stay here, folks from other places who may have means come and retire in Missouri. And so when we're looking at economic development issues, I would love to see some money invested in that front, because since it is such a large population in this country, I think when it comes to revenue generation, we could be looking that way too. And if we could invest money there too, I think that'd be great.
I could say amen to a lot of what's already been said. I will mention that I think, with these tax commissions functioning currently, that there's a lot of pressure to eliminate or greatly cut the low-income housing tax credit program. And I also have a critique of some things that are wrong with that could perhaps be improved. But I think the danger is repealing without replacing. Maybe you've heard that phrase a few places. Don't repeal without replacing with something that actually improves something. Right now, Missouri has a gap of over 125,000 units of affordable and available housing for extremely low-income families. So I'm only talking there about extremely low-income families, not all the other poor folks, and there are a lot more poor folks than that. So having housing stability is greatly in danger for Missourians right now. And I think there's, you know, a real danger in this discussion about what we do about taxes to just stop investing in affordable housing. And it's something that we should be investing more in. And in fact, if we did invest in it, it would create some great paying jobs in our communities that would then have a multiplier effect in our neighborhoods of creating other jobs, because folks were working and rehabbing and building affordable housing, affordable decent housing that would then improve health outcomes, because we don't get good health outcomes when people live in substandard housing or are homeless.
So I think I understand the question is, for government-funded programs, what
Right.
is the most need and what is the most effective or efficient?
Right.
Okay.
Yeah. Right.
So to me, it comes in two main buckets, and some of it's already been touched on, but bucket number one is health, mental health, and kind of along with that, substance use disorder, so opioid addiction. So that's all just one big area of emphasis. And in terms of Medicaid effectiveness or efficiency and low overhead, you know, that's one of the reasons why I oppose the expansion of Medicaid managed care statewide, because currently we're going to have a boatload of money going out of state to a managed care company who basically, in my own humble view, are going to ration care and take some of the savings from that rationing of care and send it to the shareholders out of state. So, you know, I don't know if you remember, we had quite an impassioned debate. We had a budget bill that only passed by 2 votes. Was it just last year? Not this paper. So, I mean, I think that's still a challenge for us, but if block grants do come down from the feds and we do have more leeway and more, you know, power, basically, I mean, we'll kind of be like the dog that caught the car. You know, it's like, okay, what do we do? What do we do now? So one of the things that I've introduced the last 3 years is a bill that this year I named it the Patients First Medicaid Reform Act. Basically takes it's not an increased funding, but it takes the money that we're currently spending on recipients and distributes them among them on a risk-adjusted basis, so the sick ones and older ones get more and the healthy kids less. But it establishes a medical savings account for each one of them, and from that they buy a catastrophic plan. And then with the money left over, they can use that for their co-pays. They could even enter into an agreement with direct primary care. That would be an innovative way to use Medicaid dollars. I don't know if you know about direct primary care. It's a way that it's kind of like belonging to a health club that you pay your doctor $50 a month, and then you can go to that office as much as you want. Everything that they have, you can access, and they don't really have to have you come to the office, because you come to the office now, you're doing that because that's the only way to register a payment. You know, you come to get what's called an E&M code. That's how you get reimbursed from Medicaid. But if you were paying a monthly subscription fee, you could FaceTime them, you could call them on the phone, they could come make a house call. It wouldn't be the typical, you got to come to the office and wait in the waiting room. You know, so that would be, and it would, I think, empower the patient more as just a normal consumer. I mean, folks in that situation don't have a lot of skin to put in the game, so we give them some skin in the game. You fund their medical savings account, and then you allow them to keep a portion of that at the end of the year, and be for various purposes. You know, you wouldn't, you know, beer and cigarettes wouldn't qualify, but you know, you would incentivize them to save some money, maybe use it for job training, maybe it rolls over to their SNAP benefits, maybe there are other ways that they could use the money that they end up saving, because now the equation has changed. It's not Joe's paying for it, so I'm going to get whatever service is most convenient without regard to cost. But once you have the cost factor in it, it's the same as it is when you go buy a refrigerator or whatever. You're looking at the cost and the benefit. So those, and then education, you know. So that collection of healthcare things and then education. One of the things that's happening since I've been in the legislature is that in states all over, the amount that we spend in our budget on Medicaid has gone up, and the amount we're spending on education has gone down. I recall just 2 or 3 years ago, it used to be like 24% for education and 21 or 22% for Medicaid, and now that's flipped. So that's something that we're seeing in Missouri. I mean, the costs of Medicaid, even without expansion, are going up substantially every year.
All right, rapid fire session, real quick. And then I'll open it up. I want quick, hard, decisive answers, and I'm going to hold you to all of them. What is the most effective way for a nonprofit advocacy group to persuade a legislator?
I think it's about building relationships with folks, and bringing people in from the programs that they work with to maybe have conversations with legislators to put a real face on different issues. So I think a lot of it is about relationships.
Yeah, I'd say personal stories. If folks don't work in this world or work with low-income folks or whatever your population may be, or come from that background, legislators just don't understand. And so I think the more personal stories we have that people can relate to and really put a face to a problem, I think that.
It really is about who you love. And unfortunately, there's a lot of people that legislators don't get to meet and love sometimes, so.
I really don't have anything to add. I think that that's absolutely right. And I guess one other thing that I'd say is bringing the work itself. I mean, nonprofits right now, and especially advocacy groups, but nonprofits are becoming our safety net providers because the budget constraints that we're having in state and federal governments, and so actually coming and talking about the work that you all are having, that you have to do.
So I've got about a 15-minute talk that I give to medical groups about this. So rapid fire, quick, okay. It's too late if your issue comes up and you don't know the legislators that are involved. I mean, the horse is out of the barn. What you have to do is develop a relationship with them early on where you're their go-to person in that area of expertise. You want to be on their speed dial for whatever issue it is. And I tell the docs, get to know your rep and your senator. Tell them you're available to be a resource for them if they need information on Alzheimer's or whatever it is. Be their resource. And then when it comes up, a bill comes up that deals with healthcare, it's like, hey, Dr. Jones. So you want to get your name in the legislator's cell phone.
I think that's very helpful. Thank you. So I will open it up. I will kind of walk around. I'll repeat your question if I hear it so that everyone can hear it, but I think it's a little easier than passing around. Dan, I'll say you first. Go ahead.
Really direct to Representative Frederick. How does establishing the PMPP,
There you go. Yeah,
how
you got
does
it.
that prevent all of the other support things that you've suggested? Certainly might be helpful. It seems like it's possible to do both.
Okay, so the question is, how would establishing a PDMP preclude some of the other benefit distributions?
It doesn't really, and when we pushed the other opioid package forward, it was like, this is completely separate from the argument of PDMP or no PDMP, because whatever happens over there, we should do all of this. And so that's the approach that we've taken.
Okay, who else? Anybody? Alex, go ahead.
I feel like most of the panel we talked about public insurance and social services, but I would ask what are the priorities and what's on the agenda to help with some of the private insurance issues that are occurring. So, I mean, we have Senti entering, but then Anthem may not be leaving. So how do you address that choice in healthcare?
Okay, so what are some of the issues facing the private insurance market and regulation in Missouri?
Well, I mean, I was actually going to talk maybe a little bit more about the federal level and what we were seeing in terms of M&As, mergers and acquisitions, and kind of the consolidation of these huge health plans. It's I say it in a very, very sarcastic sort of a way, but and it's really ironic. We're moving towards a single payer system. It's just going to be a single payer for-profit insurance company. Anthem was trying to acquire, I can't remember what the mergers were, but you've got the big four that are trying to become the big two and then become the big one. And so, back when the Obama administration was here, the FTC struck it down just because of, really concerning antitrust and issues and just it being too large. But I think that that's something that we're definitely going to have to keep an eye on. I think that what we're seeing with a lot of these insurance companies leaving the, at least the Affordable Care Act marketplace is probably a little bit to do with the FTC decisions to not allow the mergers to occur. But I appreciate you bringing up that point because that's something that we are going to have to stay vigilant in. And another point that Dr. Frederick brought up with the expansion of Medicaid managed care, even though Medicaid is supposed to be a public program, it is the trend is going towards managed care, Medicaid managed care across the country, and so I think that is another thing we're going to have to really be aware of. We all know and have probably experienced a lot of issues with just insurance companies in general, and so transparency is going to be really important. Accountability is going to be really important in trying to make sure that the managed care companies are actually not cutting services and passing the savings that they're making along to shareholders. I think that if managed care companies are saving or having or experiencing savings, those savings should return to the state. So.
One other issue just related to, in general, health insurance. I sponsored a bill this year called the Right to Shop, and it builds on some transparency. I passed a bill last year, to require our imaging centers and hospitals and surgery centers to respond within 3 days to a request for a patient for how much does this cost? Because there's wide variability of the cost. And so I think the increased use of health savings accounts, along with increased transparency, can bring some market competition to bring costs down. But the bill I carried this last year would allow patients, if they need a say you need a gallbladder ultrasound, and you get that from your doc, then you could shop that around. And if the insurance company's average payout for, let's just pick a number, let's say it was $2,000, that's too high, but let's just say it. And then you find it for $1,000 at a facility that you think the quality is fine. This bill would have required the insurance company to cut you a check for at least half of that savings. So you're motivated to go out and shop it because you might get some additional money from it. You have the ability to do it because now it's transparent pricing. They have to tell you what it is. And then the overall cost of care comes down because guess what? The people that are doing it for $2,000 are losing business to the people that are doing it for $1,000. So that's just one idea. Another idea is to get health insurance out of the employer. I mean, that just happened from the wage and price controls back in the war, and that was an additional benefit you could offer that didn't count for income. When wages were frozen, you could still offer health care benefits. That's how you attract and keep good people. But if you talk to, in the district, Jason Smith had a little round table for health care, and I had the opportunity to ask a number of the employers, do you guys really want to be in this business? And for the most part, they don't. I mean, that's just another hassle they have to do to negotiate with the healthcare providers, with the insurance companies, and find something that the employees know. So I'd like to see it get out of the idea that you're tied to your workplace. So this couple comes.
I bet we have time for 2 more quick questions. Jeremy.
So, generally speaking, when people are advocating for issues, how much of the challenge would you say is ideological opposition, and how much is interest versus disinterest? Does that make sense? So you have a policy idea. You have a policy idea. Part of it's part of the challenge is going to be obviously people who are just opposed to the policy, and part of it might be it's just not on the radar. It's just not. Everybody here, I guess from that, everybody here on this stage is fairly engaged in health policy, right? But you can't say that. I mean, that there are different priorities in both chambers. So how much of each, and how often do you encounter it?
Yeah, I'm happy to. I think there are so many bills that are filed every year. There's so much to keep up with, and I think we rely a lot on you guys and advocates to come and educate us on it. So I don't necessarily think that folks. I think it's probably a mixed bag. For some folks, maybe it's ideology, but I think on a lot of different issues, especially around healthcare, when we're talking about seniors or adults or children, I think a lot of it is a lack of education on those issues. I'm not sure if that's a great answer for you, but best guess.
Yeah, I would have to agree, it's a little bit of both, right? I learned very quickly as a new legislator, there are some things ideologically that you just can't say. So I could never go up to the budget chairman and say, we need to do Medicaid expansion, and he's gonna look at me and say, yeah, we do. It's not gonna work that way. So there are a lot of politics and rhetoric based around healthcare. But in my opinion, I don't necessarily think that that translates to belief in good policy. And so when you have conversations, like the conversations I've had with my colleagues on either side, specifically to Medicaid, when we start explaining what we see in the field, problems that people are having with whatever service, and start talking about different ideas, and transformation is a great word that Cora has given me about Medicaid, and talking about things a little bit differently, you can come up with policy solutions that aren't necessarily partisan. And it goes back to what Dr. Frederick said about relationships and relying on those relationships to have the conversation about policy and educating folks who may not understand healthcare from a perspective of your clients or whomever you're working with, then you can actually have really good dialogue and we can come up with really good bipartisan legislation. But it's about staying cognizant of those partisan conversations, that when you are trying to educate us on your particular issue, knowing who your audience is when you begin the conversation, I think is super important too. So I think it's a mixed bag of that and really just staying conscious of it while you're talking.
I think I see your question from a slightly different view. The first piece about ideology, to me, it's about how polarized we are. That some legislators that I go to see, if I take them something from the Institute on Taxation and Economic Policy, they go, left-wing think tank, and they throw it right in the trash can. And then other people, if there are times that I carry around a Show Me Institute piece because it has some data in it that backs up something that we're trying to stress, like about whether it's good economic development to give tax dollars to sports teams, for example. We see that the same way. And so maybe, these folks here in the middle would throw that right in the trash can. It's for the Show Me Institute, they're the devil. Well, can we just talk about what the evidence says and maybe stop having litmus tests about which groups are right somehow? That would be helpful, I think. And then the other piece about interested, disinterested, I see that more about who has access. And the groups that can afford high-paid lobbying teams to stay on legislators year-round have a lot of access and influence which things get talked about at the Capitol. That's a shame because that's not helping to reduce the healthcare disparities that we all care about.
I bet we have time for one more quick one.
Do you have a way of having a healthcare savings account on minimum wage? Do you know how to do that?
All right, how do you have a healthcare savings account? What benefits a healthcare savings account minimum wage?
So you mean, is there a mechanism by which an employer who's paying minimum wage could contribute to a health savings account?
Or the person?
Oh, you mean that there just isn't enough wherewithal to do it?
Yeah.
Yeah, well, I don't have the answer to that. You're right.
Okay, there was one hand. If we can do another quick one. Go ahead.
You were talking about bringing stories, to the Capitol, and we had Disability Rights Day, we had In-Home Care Day, we came up there, we brought stories, we brought consumers, we used Missouri Foundation for Health grant to help bus our consumers up to the Capitol, and they still cut Medicaid, they cut funding for the Centers for Independent Living, they cut the home and community-based services, when they're all saying, oh yeah, I know, and then they slashed the budget. So what good did it do? And we did have a relationship. My senator is Wayne Wallingford, and he was a very big advocate on behalf of Centers for Independent Living. But then you had another senator that was just adamant he was going to slash and burn. And so Centers for Independent Living got cut totally in half of our funding, and so now we can't provide a lot of the services that we were providing.
So I guess quickly, you know, what
So
are...
what good did it do?
Okay, so I guess, how effective is it to bring lobby days to the Capitol and advocate the program?
I think it goes back to what Dr. Frederick said earlier about doing it early. Those days are hugely important. And I can tell you because now I have your stories for next year when I'm in budget and have to do the fight all over again. I have your stories. So don't discredit the work that you all put in for these lobby days because they are super helpful. But that's not the only thing we can do. You know, that is one small piece of advocating on behalf of your issue. You've got to get in early in the interim, have those conversations, become our go-to person. But then you've also got to have the phone calls and the emails, and you've got to have access too. Those things also, and this is from my former art organizing days, those days also give power to your people. And it makes them feel like they are part of the process and that they are, for using a phrase earlier, they've got a stake in the game, right? And so there's value in that too, to empower people to advocate on their own behalf in terms of the betterment of your organizations. But it is effective. It may not have changed the vote this time, but I can tell you, particularly on House Committee Bill 3, those stories made people think about how they were going to vote. And at the end of the day, we did get a vote in the House on that bill. So.
And one thing I do want to just add is talking to us back home. You know, we are in the state capitol 5 months out of the year, but having those conversations in the grocery store, you know, talking to your legislator, you know, calling your legislator and sitting down and having coffee with them. I mean, that's something that I think is another sort of approach. It's always great, especially being in the super minority party, when you all come up, just because it makes us feel good, and it's just great to see friendly faces in a sometimes hostile environment. You know, I think it's also really important to talk to your legislators back in the district while they're in the district, and reminding them and having those conversations with them at home, so that I don't know. I think that is equally important, just because things get a little crazy and hectic and busy in the Capitol all the time. So just another kind of approach to the advocacy that you're doing.
So I'm just going to add on, so grassroots organizing, good public policy, and I would encourage everyone here to get involved in electoral politics. You recruit people that are going to run for office and will be a champion for these issues, and will stand up, and especially for the more vulnerable populations. So I think when we're talking about all of this, we need to think about who are the folks that we're sending there, and what are their priorities. So I would also encourage people to get involved in campaigns.
And some of us have gotten so sophisticated that we talk only to legislators and we forget to talk to our neighbors and our family and our coworkers and people that are in our community of faith. We need to actually grow the movement. We need more folks being advocates with us, and sometimes we don't bother to do that. So be sure